All right. Well, good afternoon, everyone. I appreciate you joining the GVRC Research Day and this session in particular, and for braving me for the next 15 or so minutes. Let's see here. So I am going to share with you some of the initial findings from our GVRC funded study looking at EMS providers as possible messengers of secure firearm storage. And by EMS providers, I mean folks such as EMTs, emergency medical technicians, or paramedics, or other hospital or rather pre-hospital based clinicians. In terms of disclosures and acknowledgements, just immense gratitude to the GVRC and Rutgers for the subaward, with the caveat that the views expressed here are mine and not necessarily reflective of the GVRC's, and I have no conflicts of interest to disclose. Additional gratitude to my collaborators, Dr. Melanie Hom, who's an assistant professor at Stanford University School of Medicine, whom I've had the pleasure of collaborating with for nearly a decade or so now, and Dr. Angela Wright, who's an EMS physician at the University of Colorado School of Medicine, where I'm on faculty in emergency medicine, and also is the medical director of EMS and pre-hospital care for the University of Colorado Health System, and brings in that specific pre-hospital and EMS expertise into this project. In Dr. Anesis's opening session and some of the earlier talks, you learned, or the importance of secure firearm storage was reinforced. Secure firearm storage as a fairly promising public health and clinical approach to reduce risk of suicide, homicide, and other firearm-involved injuries. I'm going to focus in on lethal means safety counseling as one vehicle to promote secure firearm storage. And so by lethal means safety counseling, what we mean essentially are discussions, often brief discussions, historically thought of between a clinician and a patient to promote secure firearm storage or help the patient identify strategies that are aligned with their value system and their circumstances that can secure a firearm in certain ways. When you think of lethal means safety counseling, you can break it down into these three components. So there's the message, kind of what is the message that's being conveyed or communicated, and kind of the content of that message. Who's the messenger? Who is conveying? I mentioned historically, we've thought of lethal means safety counseling as a clinician-delivered intervention. And then, of course, there's also the context. When and in what setting and under what situations might lethal means safety counseling be appropriate? In this talk, I'm not going to focus much on the message itself or the content of the message, although work in that area has been done. Instead, I'm going to focus specifically on a potential group of messengers and a potential unique context to the delivery of lethal means safety counseling. There's been some work including some work that was presented earlier by Ali Bond on who are preferred lethal means safety counseling messengers. So clinicians have, again, historically been thought of as the messenger. And by clinicians, I mean office-based or clinic-based or hospital-based clinicians, emergency department nurses, emergency department physicians, psychiatrists, psychologists, social workers. But several studies now have shown that firearm owners and others rate clinicians as among the least preferable messengers of secure firearm storage. By contrast, active duty service members, veterans, and law enforcement officers, these individuals in first responder roles are often viewed as preferable and credible messengers of this topic. Not only are clinicians viewed and rated as among the least preferred category of messengers, but it's also the case, and several studies now have shown that individuals who use a firearm in their suicide attempt or suicide death are less likely than individuals who use other methods to access mental health services or healthcare services in general. And so it kind of draws into question or brings into question the utility of only focusing on clinicians as messengers of secure firearm storage. What I'm not saying is that clinicians should not be doing this. Quite the contrary, they should be, but we should also start expanding the scope of folks that we might tap into from a public health kind of community approach to preventing this problem. This is where, in this study, we focus on the potential viability or suitability of EMS providers as messengers. And so on the one hand, EMS are healthcare providers. So they have specialized training in health communication related topics. And their mission is to, in many ways, improve the health and well-being and save lives. And on the other hand, they have that first responder role that we see with law enforcement, that we see with military and veterans as well, where they might tap into that credibility element as well. And some other work that I don't think has been published yet, but will be coming out soon, has also shown that EMS providers themselves have pretty high rates of firearm ownership compared with the general population. So they also have that, on the whole, at least, I'm speaking in group level aggregate here, firsthand knowledge of firearms that, again, might underscore their potential credibility as messengers of secure firearm storage. In this GVRC funded study, I'm going to present today the results from the survey portion. We're doing both a survey and then a series of qualitative follow-up interviews to really dive into some of the things that we learned through the survey. The survey had 4 aims. The first was to really just describe EMS clinicians' views on EMS-delivered lethal means safety counseling. So we're asking EMS clinicians, what do you think of this? Identifying barriers to EMS-delivered lethal means safety counseling. So what do EMS clinicians say might be getting in the way, or if it were to be rolled out, what are some of the things that we need to look out for? And then to also characterize the training experiences and the interest in lethal means safety counseling training among EMS providers. And then to examine if the way that EMS providers think about firearms and firearm-related risks, so the degree to which firearm ownership or firearm storage practices might impact suicide risk, for instance, how that might impact their views on EMS providers as secure firearm storage messengers. We conducted a web-based survey to address these aims. I won't get too much into the weeds here given time, but it was a web-based survey that we had a 6-prong approach to promote valid and reliable responding and prevent bots. As I'm sure with any researchers on this call know that web-based surveys, especially web-based surveys that offer compensation, come with some risks of bot responses, but we feel like we had a pretty solid safeguard against that. I'd be happy to share offline with folks about that strategy. So for this study, we recruited a little over 200 EMS clinicians across the United States. Their demographics matched, on the whole, what we would expect. It's not a representative sample. And at the same time, as you see here with some of these demographic characteristics, the respondents in our sample generally match the EMS population as a whole in the United States. A few things I'll just point out from this slide. About a little under half of our sample were EMTs and a little under half were paramedics. Paramedics generally have a little bit more advanced training than EMTs, and depending on the jurisdiction, can provide a higher level of care in the field. You'll notice those numbers don't add up to 100%. We had a few EMS physicians, so physicians who are specialized in emergency medicine and then complete additional training, generally through fellowship, focused on pre-hospital care. I mentioned Dr. Wright, one of our collaborators, is an EMS physician, essentially an emergency medicine doc specializing in EMS and pre-hospital care. And fairly decent geographical representation of our sample as well. So one of the questions we asked folks was, to what extent do you believe EMS personnel should deliver lethal means safety counseling to all patients? Minority said yes, 17%. Patients who report firearm ownership or access, about 50% said, yeah, maybe those would be folks that we should deliver this intervention to. A little bit more to patients with a known suicide attempt history, but the greatest support for EMS delivered lethal means safety counseling was to patients in an acute suicidal crisis. So perhaps during that time from transport to the hospital, using that as a point of intervention to discuss this topic. There were barriers to EMS delivered LMSC that we identified, the most common of which was lack of training. So 3/4 of the providers here describe lack of training as a barrier. Now, the lack of training for, and of course not strictly a mental health issue, but the lack of training for mental health and mental health adjacent topics is a problem within EMS more broadly. And so this wasn't totally surprising. And it's a very addressable barrier should this be something that moves forward. One thing to note, a little over half of the EMS providers in our sample thought that perhaps lethal means safety counseling is outside of their current scope of practice. I'm going to talk about very briefly at the end how an EMS clinician's scope of practice is determined and how that might be relevant here. There were legal concerns, including around documentation and lack of standard operating procedures. There were concerns that EMS providers might not have enough time. And of course, if you think of what EMS providers do, some of it is these acute emergent situations. Patient might either be conscious or there might not be enough time during transport, but there are situations that we're starting to learn through our follow-up qualitative interviews where it might even be more appropriate or less. Concerns about infringing on patients' Second Amendment rights and a lack of available firearm locking devices to hand out. So basically saying it's not enough for us to have these conversations, but we also, we don't have anything to support patients who say, yeah, I want to lock it up. I don't have a locking device, for instance. I'm just going to, in the interest of time, pass through that. So 70% of the EMS providers in our sample reported having received training on suicide prevention, yet only around 10% or so reported receiving any training. And we don't really know the scope of this training or the nature of this training, but 10% or so training on firearm-related topics in particular. A third of our sample reported that they assessed firearm ownership or access in their EMS capacity. One thing to note here, we're learning during some of the follow-up qualitative interviews that this is often not in the context of assessing firearm ownership or access as we typically think about it, but more presenting on scene and determining whether or not a firearm is there for on-scene safety purposes. So a little bit different, and that was a lesson learned from this survey. And so I offer that caveat as you interpret these data. Nevertheless, a very small minority reported ever delivering lethal means safety counseling. We provided a definition to participants on what this meant, but to either a patient, a patient's roommate, a family member, or friend. Promisingly, I thought about 2/3 of our sample reported an interest in receiving training on lethal means safety counseling. So on the one hand, training was identified as the primary barrier, and on the other hand, a pretty equivalent proportion of respondents said, nevertheless, I'm interested in receiving this training. Related to our fourth aim, so respondents who had more accurate beliefs about the risks of non-secure firearm storage and more accurate beliefs about the efficacy of lethal means safety counseling, those were folks who were more likely to support EMS delivered lethal means safety counseling. Not totally surprising to us, but nonetheless, again, it points to how training and education around this topic could potentially impact practices or the willing to engage in those practices. This was a convenience sample, of course, not a representative sample of EMS personnel. We only asked EMS clinicians their views. We didn't consider the views of patients, other healthcare providers in the pre-hospital chain of care or chain of command, how they might respond to an EMS provider in some contexts providing this intervention. And we didn't collect any information on participants' socio-political views, which we know from other work might impact their willingness to engage in these topics. A couple of years ago, the U.S. Surgeon General, that is a typo there, released this call to expand the cadre of healthcare professionals trained in lethal means safety counseling. And the findings of this study are definitely not dispositive on this question regarding EMS providers, but there's been some new information gleaned that we think is at least worth following up on and exploring as a potential possibility. I mentioned before, so EMS clinician scope of practice, it's determined by very local, regional, or state standards in conjunction with a medical director. There's many medical directors within a state. And so there's, on the one hand, national standards, but there's also local standards. This might, the reason I bring this up is because if this is something that gets rolled out, it could be piloted in very small jurisdictions before it's kind of piloted or rolled out rather nationally. The last thing I'll mention before I open it up for any questions folks might have is this fairly new model of healthcare delivery in the pre-hospital setting called community paramedicine. Community paramedicine is this healthcare delivery model in which typically a paramedic, sometimes an EMT, and sometimes in conjunction with a social worker, preemptively goes out into the community, often in rural areas, and acts as a physician extender, if you will, and gets people and meets people where they're at in their homes to provide preventative health care. So blood pressure screening, glucose monitoring, falls risk assessment. One of the community paramedics I spoke with said, yeah, when I go into someone's home, I look around at the rugs and see, are they curled up at the edges? And that if so, that poses an increased risk of fall, especially for older adults. And that's an example of an intervention. You can imagine how for a community paramedic who has a relationship with a patient, it's not this one-time encounter, but who has developed a relationship focused on preventative health care, that might be a really opportune time to include in the safety assessment how a firearm is stored and perhaps keep access or have some level of access to different locking devices. Because community paramedicine is so new, there's currently no national standards for it. But I think that presents, and what I've been learning from the community paramedics we've been talking to in the qualitative interviews, that presents an opportunity to incorporate as part of the larger safety assessment that they do anyway, topics related to firearm assessments and promoting secure firearm storage. And so what I think we learned from this study is that EMS is not a monolith. It's not a homogeneous healthcare delivery model whereby it's a yes or no whether or not lethal means safety counseling should be within their purview. But it might be that maybe not for the acute situations, but in this preventative community paramedicine model, it makes a little bit more sense. So with that, I will close out and see if there's any questions in the box, but please feel free to reach out to me over email with any follow-up questions. Okay, let's see, Mike. Do you think it would be viably scalable to train community paramedicine folks on how to use specific locking devices on different firearms so they could provide an education component too? Yeah, I think we have parallel findings, not from this study, that upwards around 70% of EMS in two of our separate samples reported that they personally own firearms. In this sample as well, again, a convenience sample, I think it was around 65, I don't totally remember, percent of these respondents also reported firearm ownership. So I think there's a high level of comfort and familiarity with firearms already. And I'd imagine that would translate to at least the capacity to have comfort with and familiarity with specific locking devices that they can then in turn provide knowledge to their patients. I think a challenge would be finding funding streams for this community paramedicine approach where, a paramedic's vehicle, for instance, is stocked with, or their station is stocked with a variety of different locking devices that might be more palatable to certain firearm owners. But, that's a policy intervention that I think could happen. Okay, so I don't see any more questions coming in. I'll just plot my email into the chat box if folks want to follow up. And I think it's time anyway. So I appreciate you joining. And Mike, thanks for your question. And again, thanks to the GVRC for supporting this work. And hopefully soon we'll have some of the results from the follow-up qualitative interviews to provide some more nuance, especially to the community paramedicine angle here. Thanks so much.